May I have the speaker slide? So Sayantan is going to talk about this. The Sayantan Ray, who is basically working in the clinic. So he is the GM in and a lot of publications in his credit, publications, and author of this. So with this introduction, I invite Dr. Sayantan Ray to present his
Thank you, sir, for the kind introduction. At the outset, I must thank the Endocrine Society of West Bengal for giving me this opportunity to talk on this platform. So, shall I share my slides?
Sir, you can share your slides, sir. I have enabled screen sharing.
Just a minute. Where is the sharing option? Screen. Is the screen visible?
Yes, sir.
Yes.
It is visible, sir.
And slide is moving?
Yes, sir.
Okay, thank you. So may I start?
Yes, sir.
Go ahead.
Yeah. Okay. So good evening. As already mentioned, today's topic we will be discussing for next 45 minutes or so on the current practice in patients with follicular cell-derived thyroid cancer. So before going to the presentation, I must mention some points that this area is dynamic and evolving. There are many areas where there is controversy or debate. And at present, we are mostly following the last 2015 guidelines from American Thyroid Association. So to begin with, follicular cell-derived thyroid cancers actually comprise almost 95% of all thyroid malignancies. And they are included under the umbrella categories of papillary thyroid cancer, follicular thyroid cancer, poorly differentiated thyroid cancer, and undifferentiated or anaplastic thyroid cancer. The most common tumor entity is papillary thyroid cancer, which constitutes of 80 to 85%, followed by follicular thyroid cancer, which consists of 10 to 15%. Now, follicular cell-derived thyroid cancers originate from the same progenitor cells as C-cell-derived medullary thyroid cancers. But these follicular cell-derived cancers differ in the molecular profile, pathophysiology, biological behavior, morphology, and clinical presentation. Now, we will spend a couple of minutes on this slide. This elegant illustration has been taken from a paper published in JCEM in the year 2017. So if we look at the basic histopathologic concepts for the diagnosis and classification of thyroid carcinoma, on the top panel, that is panel A and B, the black vertical bar in panels A and B actually represents the histologic border between the cases diagnosed as papillary carcinoma, that is on the left, and follicular carcinoma, that is on the right. And if we look at the four basic morphologic features that are used to diagnose tumors of follicular cell derivation, number one is papillary growth pattern. Second is follicular growth pattern. Third is presence of a tumor capsule and of its invasion. And the fourth one is alteration of nuclear morphology, typical of papillary carcinoma. So if we look at the upper panel, up to 1980s, there was dominance of follicular carcinoma diagnosis. Now, after 1980s, you will see there is dominance of papillary carcinoma. Why this is so? I will show the reasons. And in the lower panel, C and D, these all morphological features correlate with the thyroid carcinoma diagnostic subtypes, that is the panel C, and also with the molecular signatures shown here in the panel D. So unlike papillary thyroid cancer, the rate of follicular thyroid cancer diagnosis is declining over time. Why? Due to changes in the pathological criteria, that is nuclear morphology, the most important diagnostic criteria for classification of carcinoma as PTC, regardless of the dominance of follicular pattern. So that is the change in pathological criteria. That's why there is a change in diagnosis from 1980s. And second one is due to environmental factors, most importantly, iodine sufficiency. So this is the agenda for follicular thyroid cancer. I would like to discuss follicular thyroid cancer first. Since FTC is the second most common differentiated thyroid cancer histological type and has been overshadowed by its more common counterpart, that is papillary thyroid cancer. So to begin with, epidemiology and classification, we have already discussed the epidemiological data and why there is a declining in prevalence throughout the world. It is now the second most common histologic type, and the frequency of follicular thyroid cancer has been estimated between 9 and 40%. Why? Depending on the population studied, the status of iodine intake, and the pathological criteria used for the diagnosis. Regarding most important risk factor, that is, we will discuss later on. But what is important, that ionizing radiation appears to be a risk factor for PTC to a greater extent than FTC. Regarding sporadic cases, commonly present at 5th decade, is more common in women, but having a greater incidence of disease, women perform better than men in terms of outcome. So, coming to classification from the latest WHO 2017, follicular thyroid cancer has been classified into these 3 categories. One is minimally invasive. There is only capsular invasion. I will show you the pictures. That is actually limited microscopic foci of capsular invasion. Next is encapsulated angioinvasive. Here, the extent of vascular invasion is to be noted. That is number of vessels invaded, whether less than 4 or more than 4. That is prognostically relevant. And last one is widely invasive, when extensive extension is there into thyroid and extrathyroidal tissues. Now, one slide on this inherited tumor syndromes. This inherited tumor syndromes accounts for at least 5% of follicular thyroid cancers in United States. I am not going into details of that. What is important? Often FTC present here as multifocal and bilateral. And in inherited syndrome-related FTC, it affects patients at earlier age. And in familial syndrome, actually, these are characterized by actually predominance of other non-thyroidal tumors. So coming to diagnosis. Regarding clinical presentation, the most common clinical presentation of follicular thyroid cancer is a single painless thyroid nodule. In clinical practice, patients with widely invasive disease usually present with a palpable neck mass, and patients with minimally invasive disease are usually diagnosed with either a palpable neck mass or often incidentally diagnosed. Regarding pre-existing thyroid disease, it may be present in 15% of patients. Lymphocytic thyroiditis and follicular thyroid cancer may coexist, although the association remains unclear. Dysmorphogenic goiter with chronic TSH stimulation may also predispose to follicular neoplasms. Regarding metastasis and distant spread, cervical lymph node metastasis at diagnosis are significantly less common in follicular thyroid cancer as compared to papillary thyroid cancers. And follicular thyroid cancers are more often prone to hematogenous spread, which carries a high risk of distant metastasis. And regarding cervical lymph node metastasis, if present at diagnosis, it points towards a possibility of Hurthle cell carcinoma. Regarding distant metastasis, if present initially, can be seen in 15 to 30% of patients, and particularly the distant metastasis are found in shoulder girdle, sternum, skull, and iliac bone. Now, coming to ultrasonography, ultrasound features of follicular adenomas and follicular thyroid cancers actually overlap substantially. So sonographic features of FTC is actually a bit different from those of PTC. Mostly they appear as a solitary, well-defined, homogeneous, isoechoic or hypoechoic nodule with a peripheral halo with usually no lymph node enlargement. However, there are few factors which are predictive of follicular thyroid cancer instead of follicular adenoma. That is a single nodule, hypoechoic in appearance, absent, discontinuous or irregularly thick halo, and irregular margins are those ultrasound pointers. Now, another point can be noted on ultrasound imaging, that is macroscopic capsular invasion. If we do a careful imaging, that could reveal a finding suggestive of tumor protrusion. And what is interesting in ultrasonography in follicular thyroid cancers, the ultrasonographic classification system that is there in ATA guidelines that overestimate the risk of malignancy in tumors presenting with high suspicion ultrasound pattern, and it underestimates that of lesions with patterns that are considered low risk in papillary thyroid cancers. And if we look at suspicious features for PTC, that is significantly more common in Bethesda 3 atypia of undetermined significance, that subgroup, as compared to the follicular lesion of undetermined significance. Now, coming to cytopathology and molecular diagnostics, follicular thyroid cancers and suspicious for follicular thyroid cancers are not among the categories of Bethesda system for reporting the thyroid cytopathology. Why? Because the cytoarchitectural features of FTC is similar to those of follicular adenoma. And FTCs are distinguished from follicular adenoma solely by the presence of capsular and or vascular invasion, and neither of which can be assessed in cytology specimens. So interpretation and differentiation of a benign follicular lesion versus a follicular carcinoma on cytology from a thyroid nodule FNA is very, very difficult or challenging. Usually follicular thyroid cancers lacks the nuclear features of PTC. That is very important point. And molecular alterations sometimes can help in differentiating between follicular and papillary thyroid carcinoma. Now, if we look at the representative follicular lesions, now on the top left, you can see the cells are in a broad sheet with no cellular atypia. That is benign colloid nodule. On the right, up top right panel, that is follicular lesion of undetermined significance. Now look here that follicular lesion here in this cytopathology slide, the cells are started to arrange in microfollicle formations and started displaying some nuclear atypia and crowding. And if we look at the third panel, that is follicular neoplasms, the cells from forming microfollicles with nuclear atypia and crowding. So the term follicular neoplasm refers to all tumors characterized by high cellularity, microfollicular architecture, and scanty or absent colloid. Both can be benign, either benign or malignant. The reported risk of malignancy for nodules classified as follicular neoplasm varies. But what is important, follicular neoplasm diagnosis identifies a larger proportion of follicular thyroid cancers than from any other cytological diagnosis. And that is important. Now, if we combine the cytology FNA and ultrasound, on one hand, if there is nuclear features characteristic, nuclear feature of PTC with branching papilla, then it is classic papillary thyroid carcinoma, that is Bethesda 6. Now, if there is no PTC nuclei, but if there is PTC features, nuclear features suggestive of PTC, but no papilla, then if we took the possibilities from ultrasound, one is benign or intermediate ultrasound features. Then the differentials will be suspicious for follicular variant of papillary thyroid carcinoma, Bethesda 5. Other possibilities could be encapsulated follicular variant of PTC or a non-invasive follicular thyroid neoplasm with nuclear features of papillary thyroid carcinoma, that is NIFTP. Now the third part, that is there is no PTC nuclei, there is micro follicles and a large size on ultrasound. So two options, if looking benign or intermediate, then follicular neoplasm. Differentials could be adenomatoid nodule, follicular adenoma, NIFTP, or encapsulated follicular variant of PTC or follicular thyroid carcinoma. If suspicious on ultrasound, then in Bethesda 5, suspicious for thyroid carcinoma, it could be encapsulated follicular variant of PTC, or it could be FTC overtly. And the last option is poorly differentiated thyroid carcinoma. Regarding the principal molecular markers of follicular or Hutton cell carcinoma, the PAX8 PPAR gamma rearrangements, RAS mutations, and TERT promoter mutations are recurrently seen in both minimally invasive and widely invasive follicular thyroid cancers. And in follicular thyroid cancers, RAS mutations are found in 40% of tumors. Now, this stunning pictures from histopathology slides. On the left, upper left, is a follicular adenoma. You can appreciate here an intact capsule. The second one is minimally invasive, microscopic foci of capsular invasion. The third one is angioinvasion, tumor cells invading in the vascular space that may be present with or without capsular invasion. And the last one is widely invasive follicular thyroid cancers to the extrathyroidal tissue. Now, minimally invasive FTC usually carry a very low risk of persistent or recurrent disease. That is estimated to be approximately 5% only. And what I have previously told regarding angioinvasive follicular thyroid cancers, the latest classification distinguishes this encapsulated angioinvasive follicular thyroid cancer from follicular thyroid cancers with capsular invasion alone, that you may call a true minimally invasive FTC, because the presence of vascular invasion increases the chance of recurrence and metastasis. And the third point is angioinvasion usually had better survival than a widely invasive disease. Now, a differential diagnosis of follicular thyroid cancers, we can have this differential diagnosis starting from adenomatous nodule to follicular adenoma to non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Another differential could be a follicular variant of papillary thyroid carcinoma. And the last two are poorly differentiated thyroid cancer or a hyalinizing trabecular tumor. So from the characteristic findings, we can differentiate it from this differential diagnosis of follicular thyroid cancers. Regarding the NIFTP, this is encapsulated follicular pattern neoplasms, which shows a papillary-like nuclear features. But what is most important point for NIFTP is the absence of invasion. And that's why NIFTP is considered a separate entity because it carries extremely low malignant potential. So the management varies for NIFTP. Coming to the treatment part of follicular thyroid cancer, primary surgery. Most commonly, the follicular thyroid cancers are always identified after a diagnostic thyroid lobectomy. Why? Because this is the surgical procedure of choice for solitary cytologically indeterminate nodule. And actually, follicular thyroid cancers in cytology presents. From cytology, we could differentiate from a follicular adenomas. So if there is a solitary follicular lesion, it has been found that thyroid lobectomy alone was superior to both total thyroidectomy and thyroid lobectomy with frozen sections. This is a cost-effective analysis in terms of both cost and quality-adjusted life years. And from ATA guidelines, there is also no specific recommendation on the use of frozen sections. So minimally invasive follicular thyroid cancers are usually can be adequately treated with a hemithyroidectomy, provided the preoperative ultrasonography shows no lesions on the contralateral thyroid lobe or any abnormal lymph nodes. And patients with widely invasive follicular thyroid cancers on histopathology following hemithyroidectomy should undergo completion thyroidectomy. And this includes FTC with vascular invasion, that is those with, and also the complete penetration of tumor capsules in multiple areas are also high risk follicular thyroid cancers. And nearly 10% of FTCs usually involve the locoregional lymph nodes. If present, then compartment-oriented node discussion is indicated for a node-positive follicular thyroid cancers. Regarding medical therapy, follicular thyroid cancers usually retain sodium iodine symporter and thyroid peroxidase function, and therefore they can be visualized and treated with radioiodine. So for minimally invasive follicular thyroid cancers, usually do not require remnant ablation or adjuvant treatment with radioactive iodine. Follicular thyroid carcinoma patients with high risk features, that is a later stage disease or widely invasive tumors. In these areas, we have evidence that survival significantly improved in those who underwent radioactive iodine treatment. And for widespread progressive and radioiodine refractory disease, systemic treatment with tyrosine kinase inhibitors is the best approach. In this respect, two recently published randomized controlled trials are there, that is Decision and Select. Regarding TSH suppressive therapy that may be considered in patients with follicular thyroid cancers post-surgery. However, no difference between suppressive doses of LT4 and levothyroxine replacement therapy was found in terms of cancer-specific survival in patients with minimally invasive disease. So in minimally invasive FTC, probably there is no requirement for TSH suppressive therapy. Now the last slide on FTC is on prognosis. Follicular thyroid cancers tends to present at a later age. And that's why with larger tumors and a greater degree of distant metastasis. That's why they usually carry a worse prognosis than its counterpart, papillary thyroid carcinoma. However, 70 to 80% cure rate if disease is confined to thyroid. And for minimally invasive FTCs, actually behave almost similar to adenomas. And there is a long follow-up studies up to 16 years which showed 100% disease-free survival. A 20 to 30% chance of recurrence when there is regional lymph node metastasis. Extrathyroidal extension usually carries over threefold risk of mortality from follicular thyroid cancers. And as already mentioned, that FTC tends to have a greater predilection for bone metastasis than PTC. And if metastatic disease is found at presentation, it's a major risk factor for mortality. There is up to 70% of patients with this presentation could die from follicular thyroid cancers. So to summarize the FTC part, follicular thyroid cancer is the second most common form of differentiated thyroid cancer, usually present at a more advanced stage and associated with higher mortality than PTC. A potential reason for later presentation may be the difficulty in diagnosing follicular thyroid cancer by thyroid nodule FNA, which we have already discussed. Molecular markers could help optimizing the preoperative diagnosis. Surgical resection still remains the best therapy, and patients with higher risk disease usually benefited from postoperative radioiodine therapy. And the principal prognostic factors are age at diagnosis, tumor size, angioinvasion if present, lymph node metastasis, distant metastasis, extrathyroidal invasion, and also the histologic subtype. So next we move on to papillary thyroid cancers. This is the agenda for discussing papillary thyroid cancer. So to begin with, a little bit of epidemiology. As we are all aware of the fact that the incidence of thyroid cancer in United States has tripled over the past few decades. That is the past 3 decades. That is, here is a changing thyroid cancer incidence. And the reason is the diagnosis of small papillary thyroid cancers. However, the thyroid cancer mortality has remained flat. Papillary thyroid cancer are closely linked to ionizing radiation exposure, and this is actually this radiation exposure is most extensively studied causative factor for thyroid cancers. There is significant association between papillary thyroid cancers and chronic lymphocytic thyroiditis. Regarding hereditary syndromes, tumors could be of 2 groups. One is tumors associated with familial cancer syndrome like familial adenomatosis polyposis, and other group is thyroid tumors as the primary features, that is familial non-medullary thyroid cancers. Regarding somatic mutations and rearrangements, the most common chromosomal structural alteration found is red gene rearrangement, and that too increase in population subject to radiation exposure. One slide on clinical issues, mostly present between 20 to 50 years of age, however rare before 15 years, although it is the most common pediatric thyroid malignancy. Clear female preponderance. Men typically have worse prognosis. This PTC rarely interferes with thyroid function. Patients are typically euthyroid. Regarding prognosis, it's excellent. 10-year survival is nearly 93%. Recurrence of PTC to develop in about 20% of patients, and Graves' disease patients with papillary thyroid cancer usually have a worse clinical outcome than euthyroid patients with papillary thyroid cancers. Regarding the factors that could influence prognosis, number one is age at diagnosis, which have a clear relation with mortality risk. Next is primary tumor size. We will discuss this later on. Third one is multifocality. It carries a risk of recurrence, particularly in patients who have had a lobectomy. Extrathyroidal extension, which is gross, visible intraoperatively or on preoperative imaging, not the minimal extrathyroidal extension. Regarding lymph node metastasis, the important point is how they are discovered, the manner of discovery, and the number of involved nodes. Distant metastasis, commonly in lung and bones. Here, two important point is iodine avidity versus FDG PET avidity. Will come later in details. The number 7 is tumor histology. Usually, classic variant of PTC and follicular variant have favorable outcomes. Regarding oncogenes, most importantly, the BRAF, which is a serine threonine kinase in the MAP kinase signaling pathway, and this is the most commonly found point mutation V600E. Now, just one slide on histology. On the left, showing a typically branching papilla, and with this, a characteristic nuclear features must be present. That is, the follicular epithelium that is lining the papilla usually exhibits a cytologic atypia, including nuclear enlargement, nuclear groove with chromatin pallor. And on the right side, you can see a completely different picture. Here, the malignant cells forming a follicular pattern and contain a central globes of inspissated colloid. Here, colloid is blue because of the particular stain. So, the tumor cells forming the follicles actually exhibit all the same atypical features as those lining the papilla of a classic papillary thyroid carcinoma. So that is follicular variant of PTC, entirely different picture. And that's why a substantial number of follicular variant of PTC cases are initially misdiagnosed as suspicious for follicular neoplasm. So now in a table, if we see the comparison of selected PTC variants, I'm not going into details, just to mention few important area that classic variant, follicular variant, tall cell variant, diffuse sclerosing variant, and columnar cell variant, of which classic and follicular variant actually carries a good prognosis, and to some extent diffuse sclerosing variant as well, because it presents at a younger age. But tall cell variant and columnar variant usually carries a poor prognosis. And you can see here, distant metastasis is very common in the last three tall cell diffuse sclerosing and columnar cell variant. Another variant is Hoffmann variant, which also present at an older age and with more advanced disease. Now, if we look at the differential diagnosis of follicular variant of PTC, these four differential diagnoses could be there. One is FVPTC, one is follicular thyroid cancer, one is follicular adenoma, and last one is NIFTP. Now, again, not going into details, just to point out that regarding capsular invasion, will never be present in follicular adenoma and NIFTP. Regarding the metastatic pattern, again, in follicular adenoma and NIFTP, there is no question of metastasis. And usually, they develop in a normal background thyroid. So that's why NIFTP actually almost behave like a follicular adenoma, and it carries a very low risk of malignancy. However, we need to differentiate between follicular thyroid cancers from a follicular variant of PTC. Regarding mutations in papillary thyroid cancers, again, the BRAF point mutation, 90% of BRAF mutation is this B600E, could be found in 30 to 90% of cases. It carries a poorer prognosis associated with old age, locally more advanced disease. 15% are tall cell variant, already discussed regarding tall cell variant. And another important point for follow-up purpose, this is associated with low expression of sodium iodine synthetase chain. Regarding the RAS mutations found in up to 35% of cases, but it is more common in follicular variant and more prevalent in women as compared to men. Regarding the red gene rearrangements, again, could be found in 5 to 30% of 35% of cases, usually associated with radiation-associated carcinomas and more common in younger patients. Now, coming to the most important area, that is initial treatment of thyroid cancer. To begin with, a few words on preoperative imaging, which usually include a comprehensive neck ultrasonography to examine the contralateral lobe of the thyroid, the central neck compartments, often difficult to have details on ultrasonography, and the lateral neck lymph nodes. And such imaging, preoperative imaging, sometimes could change the surgical approach. And studies have shown that in up to 40% of cases, surgical approach could be changed. Regarding the advanced bulky nodal disease, if present on ultrasound, and if patient has clinical signs of symptoms of advanced disease, that is, if presenting with obstructive symptoms, then CT or MRI of the neck may be considered to search for additional metastasis in areas that cannot be visualized sonographically. Now, for a recapitulation of classical pictures of PTC on ultrasonography. To begin with, on the upper left panel, you can see here peripheral arc of microcalcifications. These are tiny punctate echogenic foci of 1 millimeter or less, may be present without a posterior shadowing. The second one is color flow Doppler ultrasonography, showing peripheral vascularity and also increased intranodular vascularity in the hypoechoic area. The third one in the upper panel is showing a taller than wide shape. That is, when the anteroposterior diameter of a nodule is longer than its transverse diameter on a longitudinal or transverse plane. That shows as taller than wide. Showing a inhomogeneous structure, it's clearly hypoechoic. You can see an arrow that is central microcalcification and a microlobulated margin. On the lower panel, the left one, the irregular thick halo sign. The second one, sometimes also not found commonly, a small cystic cavity at the periphery. And the last one, which I have kept because that the follicular variant of PTC is more likely to be iso to hyperechoic. You can see here a solid nodule which is inhomogeneous in structure, isoechoic with diffusely hyperechoic punctuations, central tiny hypoechoic area with blurred margin. So if we found a iso to hyperechoic nodule, there is more possibility of a follicular variant of PTC. So moving to the initial thyroid surgery. Surgery is the initial treatment for most thyroid cancer and is often curative for those with low risk disease. If we go back to the earlier ATA guidelines, that is of 2009, the majority of cancers measuring more than 1 centimeter were recommended for total thyroidectomy. Why? To facilitate surveillance, allowing for radioiodine therapy, and reduce the likelihood of recurrence. And if we look at the latest guideline, which Professor Majumder was mentioning, that the recent trend to the use of less radioiodine therapy actually has obviated the need to perform total thyroidectomy in many patients with low-risk thyroid cancer. We will see what is low risk later on. And risk of complications with total thyroidectomy is double than seen with lobectomy. That point further strengthening the argument of a less extensive surgery. And most importantly, several retrospective studies have revealed that outcomes are equivalent in patients with low-risk disease treated with lobectomy compared with total thyroidectomy when controlled for tumor size and extent of disease. Another controversial area is low-risk differentiated cancer, which is between 1 to 4 centimeter. The recommended extent of surgery for patients with PTC measuring 1 to 4 centimeter, the options are more traditional approach of total thyroidectomy and the newly endorsed thyroid lobectomy. The arguments for total thyroidectomy includes a possibility of multifocality and contralateral disease, always a potential for second surgery, adequacy of resection, which is often found not that if we do a 2-stage operation, and also to facilitate detection of residual and recurrent thyroid cancer. On the other hand, arguments for thyroid lobectomy, one is avoidance of thyroid hormone replacement, but there are counter arguments as well, because the TSH range to be maintained here is 0.5 to 2, and it has been found that to maintain it below 2, most patients will require thyroid hormone replacement. Next point is little impact on quality of life. It's okay. Decreased risk of complication, which already discussed, and probably equivalent recurrence and survival. Of course, there are additional considerations like patient preference as well. And if we look at the very low risk tumors, that is less than 1 centimeter, papillary microcarcinomas, there is also controversy between either active surveillance or thyroid lobectomy. Now, regarding lymph node dissection, papillary thyroid cancer has a high predilection for spread to locoregional lymph nodes, occurring in up to 40 to 90% of cases when prophylactic node discussion is performed. However, it has been found that recurrence-free survival is not affected by the removal of sonographically normal, microscopically diseased nodes. And prophylactic central neck dissection may be considered on an individual basis for those patients with T3 or T4 tumors or in the presence of lateral neck metastasis. And of course, the risk of surgical complications with nodal dissection should be weighted against the benefit of lymph node removal. And another point to mention here that berry picking or selective removal of suspicious lymph node metastasis is usually not recommended. Coming to the next part, that is radioiodine scan. So this is again a frequently debated area. So for to make it relatively easier, we can subdivide the radioiodine scanning to these 4. Number 1 is pre-iodine therapy staging scans, that is performed after patient's first surgery. Next is post-therapy scans, that is performed 3 to 10 days after the I-131 therapy. Third one is follow-up, surveillance or baseline scans performed usually 6 to 18 months after the initial radioiodine treatment. And the fourth one is restaging scans performed when recurrence and or progression of DTC is suspected. Now, for the number 1, that is pre-iodine therapy staging scans, the most controversy is there because one argument is that everything I need to know I could learn on the post-therapy scan. Another argument is that it may cause stunning. However, to avoid the stunning effect, we can use a lower the prescribed activity of I-131, that is 1 to 3 millicurie. Now, coming to the terminology and goal of I-131 therapy, which is an umbrella term, 3 possible aims of performing radioiodine therapy. 1 is remnant ablation, that is use of I-131 to destroy the normal thyroid tissue. Second one is adjuvant treatment, that is use of I-131 to treat possible microscopic foci of disease not demonstrated on imaging. And the third one is treatment of known disease, that is to treat known residual locoregional disease or distant metastasis or both. So if we look at this, all these 3, for remnant ablation is not associated with improved disease-specific survival or disease recurrence or improving progression-free survival. But regarding adjuvant treatment and treatment of known disease, they could be given with a curative intent, and adjuvant treatment is associated with improving disease-specific survival, recurrence, and progression-free survival. Now, another controversial area is thyroid hormone withdrawal versus using recombinant human TSH. Now, for diagnostic radioiodine imaging or for I-131 therapy, patient must be prepared with either thyroid hormone withdrawal or injection of recombinant TSH to stimulate the normal thyroid tissue and or functioning differentiated thyroid cancer to take up the administered radioiodine. Now, these two papers published at the same time in New England Journal of Medicine by Schamberger et al. And Malik et al. No statistical difference in the success of I-131 remnant ablation in patients who were prepared when with either thyroid hormone withdrawal vis-a-vis recombinant TSH use. US FDA approved and expanded the use of recombinant TSH, that is thyrogen, after publication of these two papers. And as per the ATA 2015 guidelines, preparation with recombinant TSH stimulation may be considered as an alternative to thyroid hormone withdrawal for achieving remnant ablation and also prior to adjuvant treatment. But currently, recombinant TSH is not approved by the FDA for preparation of I-131 for treatment of distant metastasis. Another frequent controversy, that's why, is use of thyroid hormone withdrawal versus recombinant TSH in ATA high-risk disease or distant metastasis. So from practical point of view, in those patients whose comorbidities make thyroid hormone withdrawal an unacceptable option, preparation with recombinant TSH is a reasonable alternative, and we should offer both options to patients and let patients decide based on their priorities rather than our priorities or bias. So to summarize the radioiodine imaging and therapy part, if properly performed, radioiodine scans are valuable diagnostic staging tools. When performed before first time iodine therapy, 3 to 10 days after therapies, and approximately 12 months after I-131 therapy to establish a new baseline scan. And of course, restaging scan is important when there is evidence of progressing disease, because I-131 therapy is a potential option for them. Remnant ablation already discussed. The last one, this amount of prescribed activities for remnant ablation, adjuvant treatment, and treatment of distant metastasis still remain controversial. However, most authorities advocated a 30 to 50 millicurie for remnant ablation and 100 to 150 millicurie for adjuvant treatment. The most important point here is that before patients are considered radioiodine refractory, which thereby eliminates an option of I-131 treatment, which is actually potentially beneficial to patients, the physician must confirm patients are truly radioiodine refractory. I will come to that. Now, this three-tiered risk stratification system for differentiated thyroid cancer, this is adapted from ATA Management Guideline 2015. I am not going into details, but you can see patients are categorized as having low risk, intermediate risk, or high risk in terms of recurrence. And risk estimates are shown here. For low risk, it is less than 5%. For intermediate risk, it is 5 to 10%. And for high risk, it is more than 20%. Now, regarding the indications for radioiodine therapy, to cut this long story short, that radioiodine therapy is still being discussed controversially in low risk and intermediate risk patients. You can easily appreciate from this table. But there is a consensus that all high-risk patients should routinely receive radioiodine therapy, because you can see here, radioiodine improves disease-specific survival as well as disease-free survival in high-risk category. And studies have consistently shown that patients with ATA low risk, that is tumor less than 1 centimeter, lacking nodal or distant metastasis, usually do not benefit for radioiodine therapy. Regarding the intermediate risk group, depending on tumor size, presence of extrathyroidal extension, presence of lymph node metastasis, and also considering the age of the patient, we can consider post-operative radioiodine therapy. So this is a simple algorithm for management of differentiated thyroid cancer post-thyroidectomy. So conventionally, 3 to 4 weeks after total thyroidectomy, a low dose of I-131 scintigraphy is performed to assess the presence of residual thyroid tissue and also to quantify the amount of remnant tissue either by a thyroid uptake or by a planar imaging. And following the I-131 ablation or treatment, post-therapy I-131 whole body scan is performed 5 to 7 days later to ascertain whether there is optimal concentration of I-131 in the residual thyroid tissue and known metastatic foci, and also to screen for patients for any unsuspected regional or distant metastasis. And at 6 months, I-131 whole body and neck scintigraphy is usually performed to assess the success of I-131 ablation. Thereafter, usually a yearly follow-up is done with whole body scan and thyroglobulin, usually of LT4. For high-dose I-131 therapy, usually a fixed dose is favored. That is 100 to 120 millicurie is administered orally in patients with lymph node metastasis. In patients with pulmonary metastasis are treated with 150 millicurie, and those with skeletal metastasis are administered 200 millicurie as one-time dose. Now, after the TTC is treated with total thyroidectomy and radioiodine therapy, here we have classified the response to therapy. Type of response could be excellent, indeterminate, biochemical incomplete, or structural incomplete. For excellent response, it requires all 3 definition components. That is a negative imaging findings, the serum thyroglobulin non-stimulated less than 0.2 and stimulated less than 1, and the anti-TG undetectable. And you can see the proportion of patients in the low, intermediate, and high risk achieving the excellent response. it is nearly 90% for low risk category. And regarding prognosis, only 1 to 4% of recurrence and a less than 1% disease-specific mortality. For intermediate response, disease is stable and resolves in approximately 80% cases. And then response is reclassified as either structural or biochemical incomplete and may prompt additional therapy in the remainder 20% of cases. For biochemically incomplete lesions, then when imaging is negative, can be defined either by serum TG level or anti-TG antibody trained. And regarding the structural incomplete, it is structural or functional evidence of residual disease irrespective of TG level and anti-TG trend. It is the only type of response for which disease-specific mortality is significantly elevated, up to 11% if locoregional metastasis and up to 57% if distant metastasis. And regarding the equivocal imaging, that means either a non-specific structural finding or a faint uptake on iodine imaging. Now, if non-specific imaging findings are accompanied by a serum TG level of more than 1 unstimulated or more than 10 stimulated, then classifying these patients with structural incomplete lesion is more appropriate. So I am not going into discuss this slide, already discussed, just to mention that for patients with total thyroidectomy without radioiodine remnant ablation and for patients with lobectomy, there are proposed definitions as well, but these definitions need further validation. Coming to the last part of PTC, that is follow-up protocols. For patients with low risk papillary thyroid cancer, usually underwent lobectomy. If there is absence of structural disease, the TSH, suppressive TSH therapy target is 0.5 to 2. Usually a neck ultrasonography is advised 3 to 5 years after primary treatment, and assessment of thyroglobulin and thyroglobulin antibodies every 12 to 24 months, and we should consider the trend. For low to intermediate risk, usually total thyroidectomy with or without remnant ablation. Again, for excellent response, the first 2 points of low risk to include FDG PET, 18 fluoro FDG PET, or a diagnostic whole body scan if there is a rising trend in thyroglobulin or thyroglobulin antibodies. And same is for a biochemical incomplete or intermediate response. Regarding the high risk, if there is excellent response, consider a suppressive TSH therapy and neck ultrasonography. But for biochemically incomplete or intermediate response or a structural incomplete response, the target TSH is less than 0.1. Neck ultrasonography recommendation is same. And again, here also, 18 fluoro FDG PET or a diagnostic whole body scan if a rising trend in thyroglobulin or thyroglobulin antibodies. Now, what is important? Radioiodine diagnostic whole body scan, preferably with a SPECT, that is single photon emission CT, is also another option if we don't go for FDG PET. And another point I would like to mention here that after 5 to 10 years of follow-up with no evidence of disease, the risk of recurrence is so low that patients can then be safely monitored on an annual or biannual basis with serum TSH. That levels should remain within the lower part of normal range, and serum thyroglobulins, which should remain undetectable. So this is the TSH target range for excellent intermediate biochemical incomplete and structural incomplete response. What is important? The optimal TSH range should consider the initial risk for recurrence, the response to therapy, and also the risk for thyrotoxicosis related morbidities showing on this left side in the individual patient. And target TSH for the individual patient may evolve over time depending on the response to therapy. And last but not least, lowering the TSH to undetectable levels probably doesn't confer additional benefit beyond that seen with less aggressive suppression as shown in this particular study. So next to discuss few tools for follow-up. One is serum thyroglobulin, which can be produced by both normal and neoplastic thyrocytes. So given the lack of standardization between assays, thyroglobulin should always be measured using the same method, either following a classic assay having a functional sensitivity of 1 nanogram per ml or an ultra-sensitive assay with a functional sensitivity of 0.1 to 0.2 nanogram per ml. And here also the sensitivity of serum thyroglobulin assay with a detection threshold of 1 nanogram per ml can be increased by stimulating the TSH secretion either by a long-term levothyroxine withdrawal or injections of recombinant TSH. And the negative predictive value of undetectable TSH stimulated TG level is close to 100%, which the implication is further monitoring of stimulated TG usually offers no additional benefit. And the second recombinant TSH stimulated TG is informative in patients, only in patients who had the first stimulated TG detectable. So with the availability of ultra-sensitive thyroglobulin assays, actually has removed the need for routine TSH stimulated thyroglobulin determination, because TSH stimulation produces a 5 to 10-fold increase over the basal values of serum levels of thyroglobulin. So using a sensitive assay, TSH stimulated serum levels can be predicted. And the cutoff using the best accuracy for basal sensitive thyroglobulin has been reported as 0.2 to 0.3 nanogram per ml. Regarding anti-TG antibodies, these antibodies can interfere with measurement of serum thyroglobulin. So the presence should always be assessed at the time serum levels of thyroglobulin are determined. So in presence of thyroglobulin antibodies, the results of serum thyroglobulin assays cannot be reliably interpreted. That's why monitoring anti-TG antibody titers over time using the same assay can provide a surrogate information on disease recurrence, and in clinical practice, a declining titers are usually associated with remission. Depending on the immunoassay used, we can have a false negative or less frequently a false positive results.
Sayantan, can you wrap up quickly?
Yes, sir. Only a few slides are there. Regarding cross-sectional imaging, which are usually not indicated routinely, the use of SPECT-CT in addition to or instead of a planar whole body scanning actually allows an exact anatomical localization and thus a better characterization of foci with increased I1-3-1 uptake both on post-therapy imaging as well as on diagnostic imaging. Regarding FDG PET-CT, can be complementary to I1-3-1 whole body scan, even in the presence of detectable I1-3-1 uptake in metastasis, because FDG uptake may be present in neoplastic foci with or without I1-3-1 uptake. And it can identify DTC relapse early and predict response to radioiodine, because differentiated thyroid cancer cells de-differentiate, their radioiodine uptake decreases and glucose metabolism increases. That is called flip-flop phenomenon. Now, if we look at this whole body scan, planar anterior whole body image, that is showing an intense neck radioactivity. Now, if we look at the PET-CT at mid-neck level, that is B and C, it demonstrates a focal uptake that is compatible with iodine-avid residual local thyroid disease as also nodal disease. And the SPECT-CT at the level of thoracic inlet, that is D and E, shows a left paratracheal iodine-avid lymph node. There is also a soft tissue mass destroying the adjacent T2 vertebra that is without a focal radioiodine uptake, that is non-radioiodine avid bone metastasis. In whole body image showing a faint increased stressor uptake in the liver dome, that is a posterior image. Now, if we do a fused SPECT-CT image, this co-localizes to a I1-3-1 avid pulmonary nodule at the base of the right lung. And the last one is FDG PET-CT showing a metabolically active left anterior neck nodes. And FDG usually exhibits a high specificity in detection of metastatic lymph nodes in patients with DTC. And you can see here that in iodine imaging is negative for this nodal metastasis. So quickly, a clinical indication, you can see here only for a suspicious DTC relapse and negative diagnostic I1-3-1 or I2-1-2-3 whole body scan, we have the greatest evidence base for FDG PET as well as it is indicated in clinical practice. So the last few slides on one is on tennis. That is one of the most challenging clinical situation in patients with DTC having an elevated serum thyroglobulin levels. Usually the consensus is that at least TG level more than 10 nanogram per ml or showing a fast doubling time. And these patients usually present with a negative radioiodine scintigraphy. Before making a diagnosis of tennis, we should exclude this 4-point iodine interference. We know that imaging characteristics of I1-3-1 are relatively inferior to those of I1-2-3. A false positive elevated TG level could be related to anti-TG antibody or heterophile antibody, and a nodal recurrence should be ruled out. And these nodes are frequently negative for sodium iodine importer and therefore do not show up. So if all these pitfalls are ruled out with certainty, then we should do an attempt to find treatable disease and foci. Here is a decision-making stepwise algorithm for management of tennis. What is important that when operable disease is detected, like a neck lymphadenopathy, as the sole site of metastatic disease, appropriate surgery is the treatment of choice. But with respect to distant disease, operability needs to be considered on case-to-case basis. And in this context, a negative FDG PET scan without any obvious anatomically delineated disease in the setting of raised TG level is a strong favorable prognostic marker, and we can go for empirical I131 therapy for inoperable disease. And FDG uptake on PET in patients with metastatic DTC is a major negative predictor for response to RAI treatment and an independent prognostic factor for survival. The last part is radioiodine refractory disease. There is currently no definition or fixed criteria by which patients can safely classified as radioiodine negative. We need individual assessment, as also emphasized by Tuttle and colleagues in the latest consensus recommendation. It implies generally that treatment with I131 is no longer effective, and discontinuation of this concept must be considered if patient with one or more vital tumor lesions without iodine uptake. And tumor progression within a short period of time, that is 6 to 12 months after RAI therapy, regardless of the RAI avidity of those lesions. So these are the clinical scenarios that could suggest that a patient may have iodine refractory thyroid cancers. However, a negative diagnostic scan decreases the likelihood that patient's thyroid cancer is I131 refractory, but of course, it is not an absolute criteria. So here is an algorithm for decision making when a radioiodine refractory thyroid cancer is progressive. The bottom line is that whenever possible, a local treatment, including surgery, should be preferred, and systemic therapy should be postponed until evidence of a multi-metastatic progressive disease is there. And the recent trials are actually aiming at redifferentiating non-iodine avid tumors with BRAF inhibitor dabrafenib, and tumors that carry the RAS mutations are more likely to be RAI avid than those carry a BRAF or TERT mutations. The reason we have already discussed. So to summarize, if we compare between PTC and FTC, both are differentiated thyroid cancers. Higher incidence for PTC, manifestations at a younger age, median age is shown here. Higher female to male ratio for PTC, usually smaller primary tumor size. Higher incidence of multifocalities seen with PTC. Frequent extrathyroidal extension with PTC. More cervical metastatic lymph nodes are present with PTC. However, less distant metastases are found in PTC. Regarding the 10-year cause-specific survival, freedom from distant metastasis, and locoregional failure, if we look at the figures for PTC compared to FTC, of course, the 10-year survival is better in PTC as compared to follicular thyroid cancers, and reasons we have already discussed. So thank you very much, and I shall conclude here and be happy to take questions if there is.
So thank you, Dr. Sayantan. I'm Dr. Goswami here. Professor Majumder had to leave midway because there was something important urgent, but I realized that you have made a very elaborate and extensive presentation, so much so that there's no question left to be asked, I think. But I think it will rather encourage our students to go further into the topic. There are still gray areas, as we got to see from your presentation, but you made an excellent job, and the very detailed presentation will help our students, at least in facing their exams and in facing patients in real life. We need to study in this areas. Research is also being done. Also from SSKM, we have had good publications here. So I thank you from on behalf of the Endocrine Society of Bengal for this very excellent lecture. We have the YouTube recordings of these lectures available. They will be uploaded to the YouTube channel of Endocrine Society of Bengal. So for those who could not join today, if you wish, you can share the links with your friends and colleagues so that they can go through this extensive lecture at their leisure. Our next meeting will be on the 1st of October, where Dr. Mohan Shenoy will be speaking on thyroiditis. We will give the details of that meeting later on. So thank you everyone, and have a good night. Take care. We'll meet again on the next meeting date. Thank you, Dr. Ray, for your brilliant effort. Thank you.
Thank you, Shomikda. Good night.